Thank you very much, Nabil. Great talk. And we'll move on to our next speaker, who's Sonia Branci, who's from a radiology registrar from Copenhagen, who's done a lot of research in the groin and is going to give us an overview of the imaging literature.
Thank you. Okay, I will try this microphone and see if it works. Yes. Good morning, everyone. My name is Sonia Branci, and I'm a doctor from Denmark. I've been conducting a PhD study on radiological findings in soccer players, actually, with long-standing groin pain. But today I will talk about the imaging literature overview that we have also been working on with this PhD. First, let me introduce the work group I've been a part of. I've been working with Dr. Per Hulmich from the Sports Orthopedic Research Center Copenhagen and Christian Thorborg, that you have met and seen already. And I've also been working with Professor Michael Bachmann-Nielsen and Dr. Birte Højlund Bech from the Radiology Department of Rigshospitalet in Copenhagen. So, well, as you very well know by now, soccer is a very popular sport worldwide, and long-standing groin pain is a very common problem. And the estimated incidence of new hip and groin injuries is 10 to 15% of elite soccer players each season. But the prevalence of hip and groin pain is much higher and is estimated to affect about 70% of male soccer players during a season. It's been shown that adductor-related groin injuries are the most common groin injuries, and adductor-related groin pain is the most common clinical entity encountered in professional soccer players. So in the context of the PhD project we've been doing, we wanted to know and we wished to examine what the current evidence actually is concerning radiological findings in symphysial and adductor-related groin pain. And those are two clinical entities where the symptoms experienced by the patient can be related to the symphysis, but also to the adductor muscle insertions to the pubic bones. And we published a study in 2013, actually a review article, where we performed a critical review of existing literature, existing radiological findings on this topic. So how did we do it? We performed a search in Medline back in 2012, and we had a set of inclusion and exclusion criteria. And our inclusion criteria were that we wished to find original studies that were dealing with radiological findings in symphysial and adductor-related groin pain. We wished to include studies that used the main modality MRI, radiography, and ultrasonography. And as exclusion criteria, we had the fact that we didn't want to look at reviews, case reports, herniography studies, or cadaver studies. We were not interested in surgical studies either, and we did not include studies where the main modality, radiological modality, would be computer tomography, because we were not interested in acute trauma, and we did not include isotope bone scans either, mostly because they're rarely used nowadays. So after applying those inclusion and exclusion criteria, our initial search yielded 252 articles up here, and we ended up with 17 articles, of which 12 were MRI studies, 4 were radiography studies, and 1 was an ultrasonography study only. So if we look at those results in 2012, we had a total of 17 studies, and 10 of those were case-control studies, and 7 were case studies only with no controls. And they were all cross-sectional. They were quite different in terms of sports types practiced by the participants in those studies, but also in terms of ages and sex of participants. 14 of these studies included an initial clinical examination, but in only 2 studies did we actually know how those patients had been examined. And only 10 studies would use the same radiological protocol for all participants. Since 2012 and the search we performed at that time, some extra studies have been performed. 2 have been published, one by Philip Robinson and his group, and another by Murphy and his group in 2013. We have also just had a study accepted for publication on this very topic, and I will provide you with an update of these studies as well after talking about the result of this review article we did. So I would say today, actually, we have a total of 20 studies, 12 are case control and 8 are case studies. However, one of the main challenges when we try to compare and evaluate these studies side by side is the fact that there's a large lack or important lack of consensus regarding diagnostic terms, diagnostic criteria, and definitions used by the different authors. Different authors may use different diagnostic terms, but even when they use the same diagnostic term, for example, osteitis pubis, they might define it completely differently from one another. So it's very difficult to know which clinical entities the different study participants are suffering from in a given study. So what we did, we evaluated all of these articles, and then we reclassified the radiological findings, not based on the radiological terms used by the authors, but based on the actual description within those articles. And we were able to categorize them into 4 main groups, the first 4 groups listed on this slide. And I've also added a 5th radiological finding that we did not include in our review, but that's a new finding that was described last year by Murphy in 2013, and it's called the superior cleft sign, and I will come to that as well later. So I will briefly give you a description of each of these categories of findings. So the first type of finding is degenerative changes at the symphysial joint. Well, that's what we decided to call it. It's really similar to osteoarthritic changes at the symphysis. And degenerative changes at this joint, they would consist of joint space narrowing or widening, subchondral sclerosis or subchondral cysts, bony proliferation at the superior margins of the joint, also called beaking, and some degree of central disc herniation here at the pubic symphysis. Those are coronal images, as you can see on the scan plane here. So when we look at the evidence for this particular finding, 2 radiographic studies have reported a higher prevalence and a higher severity of degenerative changes at the symphysis for symptomatic athletes compared with non-athletes. But importantly, degenerative changes have also been reported in asymptomatic athletes and in non-athletes. And it seems that the prevalence of these changes increases with age. 7 MRI studies have reported a higher prevalence of degenerative changes in symptomatic athletes compared with asymptomatic athletes. The second type of radiological finding is pathology of the adductor muscle insertions, and it's not been defined explicitly in any of those available studies. But on MRI scans, when you examine the adductor tendons on fluid-sensitive sequences, you might see increased signal intensity within the tendinous structure, as well as bulging of the adductor tendon. And the adductor tendon should normally look well delineated and black and slender on both T1 and T2 weighted sequences. Of available studies published up till 2012, 2 MRI studies have reported a prevalence of pathology, adductor muscle pathology, tendon pathology, in 71% of a group of symptomatic professional athletes and in 46% of a group of symptomatic recreational athletes. The third type of finding is pubic bone marrow edema. And pubic bone marrow edema has been described in several studies, really. And the way you see pubic bone marrow edema is by looking for diffuse increased signal intensity within the pubic bone marrow in relation to the symphysial joint margins. And it should be distinguished from physiologically occurring red and yellow bone marrow that you would find in the pubic bones in all subjects. You can also see this diffuse increased signal intensity here on those coronal images. So pubic bone marrow edema has been the subject of considerable interest in several studies because its presence has been suspected to be correlating with the severity of long-standing groin pain. And 9 MRI studies have reported pubic BMO, and they've reported prevalence of pubic BMO in between 28 to 100% of symptomatic athletes. And in studies that have also included asymptomatic athletes, they have found pubic bone marrow edema in up to 65% of those asymptomatic subjects. So this really raises the question of what is the significance of this finding. The fourth type of radiological finding described is the secondary cleft sign, and the secondary cleft sign is visible on coronal fluid sensitive sequences as a curvilinear area with a signal intensity of fluid that extends inferiorly and laterally from the inferior margins of the pubic symphysis. The secondary cleft sign has been found in 52, 67, and 88% of symptomatic athletes in 3 different studies, and in all cases the secondary cleft sign would be present on the symptomatic side of those athletes. The secondary cleft sign was reported in none of the asymptomatic controls in the studies that had control subjects. So the secondary cleft sign has been suggested to represent the possible consequences of micro tears at the site of the adductor insertions to the pubic bones, and thus be the sign of an indirect lesion of the adductor tendons at their insertion to the pubis. The fifth radiological finding that I will briefly describe here is the latest that's been published in 2013, and it's a line with the signal intensity of fluid that extends inferiorly and parallel to the inferior margins of the superior pubic ramus. And as opposed to the secondary cleft sign, it's located much more anteriorly and superiorly. And the authors of this study suggest that it may represent a lesion at the site of the rectus abdominis adductor longus attachment site. But it's not been proven, really. So the conclusions of this review is, well, we described 4 main radiological findings. There are at present 5 findings described in the literature. But one of the main challenges is really that there are only relatively few studies on this subject, and the diagnostic terminology is confusing. The available studies have very different study designs and are very heterogeneous in terms of clinical examinations and radiological protocols used to describe the participants. And there's also a lack of reliability assessments. And so digging into current evidence really, makes apparent that there's a lot of uncertainty concerning the significance of MRI findings. And if I would sum up what I've just been telling you, we know that pubic BMO has been reported in between 28 and 100% of athletes with long-standing groin pain, but it's also been reported in up to 65% of asymptomatic athletes. Adductor tendinopathy has been reported in roughly half of athletes with long-standing groin pain examined in those studies, but those studies have not included controls to compare with. And degenerative changes at the symphysis have been reported in between 20 and 98% of athletes with long-standing groin pain, but up to 50% of asymptomatic athletes. So this raises a number of questions. In studies with symptomatic athletes only, would we also have found positive MRI findings if they had included asymptomatic athletes as well? And many of these different symptomatic athletes are practicing very different types of sports. So are they really comparable? And would those sports type in themselves be able to produce positive MRI findings? In case control studies, control groups are often ill-matched with the cases in terms of sports types practiced, sexes, and ages of study participants. Briefly, I'll just tell you about a Philip Robinson's study that was published recently. And what is really interesting about this study, Philip has been looking at elite soccer players. Soccer is a sports type that is good as a model for investigating long-standing groin pain in athletes because groin pain occurs very frequently in these athletes. And what is interesting in Philip's study is that out of 3 soccer players with long-standing groin pain, 2 had normal MRI findings or normal scans. Conversely, asymptomatic soccer players in this study, and I hope that I cite the numbers right, I made it up to 21 in total, and of those, 8 had normal MRI scans. In a study we have just recently conducted, we compared 3 groups of participants. We compared a case group consisting of soccer players with adductor-related groin pain, a specific clinical entity. We compared them with a first control group consisting of asymptomatic soccer players of matching age and activity level. And we also compared with the asymptomatic non-soccer players that we knew had never played soccer in an organized setting, and they were matched for age and activity as well. And very briefly, I will not go into details, but what is apparent when we look at the results of our study is that soccer players in general display higher prevalences of positive MRI findings for a number of findings compared with asymptomatic non-soccer players. And for the statistical analysis, I'll not go into details for that as well, but when we compared symptomatic soccer players with asymptomatic soccer players in the first step, the difference between participants in this group being whether or not they had symptoms of adult-related groin pain, we would find that only 2 findings would display a statistically significant difference. That would be disc protrusion at the pubic symphysis and higher grades of pubic BMO. Conversely, when we compared asymptomatic soccer players with asymptomatic non-soccer players, the only difference here being whether or not they played soccer, we would find statistically significant differences for many of the MRI findings listed on this protocol. So overall, the conclusion of our own study would be that soccer players would, irrespective of whether it was symptomatic or not, would not overall display significant differences in their MRI findings. Non-soccer players, on the other hand, would have mostly normal MRI scans, and we would find significant differences between asymptomatic soccer players versus non-soccer players, but not for soccer players concerning the ones with symptoms and those without. So the conclusion of this presentation is that actually there's a shortage of radiological studies on athletes with long-standing groin pain, and the diagnostic terminology is quite confusing. It seems that soccer players with long-standing groin pain, as well as asymptomatic soccer players, often display positive MRI findings related to the symphysis and the adductor insertions. On the contrary, non-soccer playing asymptomatic athletes display mostly normal MRI findings. And this really raises the question of whether positive MRI findings seem to be related to soccer play. Well, first of all, it does underline the fact that it's important who we match our symptomatic athletes with, because we can see that from this study. And it also really raised the question of how sensitive is MRI to detect findings in athletes, because many athletes will have positive MRI findings, but that would not necessarily be a sign of whether they have symptoms of groin pain. Thank you very much.